My name is Dr. Ayesha. I am working as a house officer in DHQ Hospital, Allied Hospital, Pakistan. I am extremely grateful to California Institute of Research and Technology for providing me with this opportunity to present at the symposium. I'm also very grateful to Dr. Barney, who has been my mentor throughout this process. So today we're going to be presenting a case on folic acid and B12 deficiency leading to infarctive stroke. Vitamin B12 and folic acid are necessary for the metabolism of methionine, which is an essential amino acid present in our bodies. Methionine is metabolized to homocysteine and it's further broken down and processed. When the body is deficient on vitamin B12 and folic acid, homocysteine metabolism is impaired, leading to elevated levels of homocysteine in the blood. Hyperhomocysteinemia can lead the body into a hypercoagulable state, while several mechanisms like impaired fibrinolysis, increased platelet aggregation, endothelial damage, and increased oxidative stress. This can lead all of these processes can lead into atherosclerosis and consequently lead to infarctive stroke or cardiovascular complications like MI or heart attack. So today the case we're going to present is of an 18-year-old young male boy who presented to us in a medical emergency with right-sided body weakness for 2 days. There were no other associated neurological symptoms like headache, vertigo, vomiting, dyspnea, and impaired vision. But the patient had impaired sensation of body position and vibration. Now, on examination of the patient was vitally stable. There was no slurred speech, but there was decreased power in the right side of the body. The power on the right side was 2/5, and it was 5/5 on the left side. The plantar responses on the right side were outgoing, and the pupils were reactive to light. Now, this appeared to be a case of ischemic stroke in a young patient who did not have any other comorbidities like hypertension, diabetes mellitus, or dyslipidemia. The past medical history of the patient was insignificant for any history of trauma, stroke, or previous congenital heart disease. The family history is also unremarkable as both the parents were non-diabetic and non-hypertensive. Now, in ischemic stroke, the first thing we need to do is perform an ECG, a CT brain, an echocardiograph to rule out the causes of the stroke. This patient had a parietal lobe in ischemic infarct on CT brain, a right-sided ischemic infarct in the parietal lobe, which explains the patient's impaired body position and vibration senses. Then the ECG of the patient came back completely normal. The echocardiogram is also normal. The lipid profile also came normal. This makes the cause of stroke unknown. Now, in a young patient, the ischemic stroke is very rare. It's something that is very rare to occur. So we need to dig in depth to find out the cause of the stroke. So we started with the basic blood investigations. The CBC of the patient showed a hemoglobin of 6.5, which is anemic, and an increased MCV. That's all the clue that we got from the CBC. The peripheral blood film showed hypersegmented neutrophils, and that indicates megaloblastic anemia, which possibly explains the vitamin B12 and folic acid deficiency. Then on further labs, the patient's LFTs came normal. However, the LDH was raised, and the other abnormalities were noted in the prothrombin time, which was mildly elevated, and the activated partial thromboplastin time, which was raised to borderline. Now, the further investigations, including the ultrasound, abdomen, chest X-ray, was also normal. Now, the first clue that we had was only from the CBC, which showed a megaloblastic anemia that was due to vitamin B12 deficiency. In young patients, we usually suspect vasculitis to be a cause of the stroke. So we performed the direct and indirect Coombs test in this patient that also turned out to be negative. The patient also expressed dyspnea exertional dyspnea on walking and leg pain, for which D-dimer was performed, which could be one of the reasons that the patient had a formation of thrombus, which may have led to an embolus, which was dislodged into the brain and caused the ischemic stroke. The D-dimer test also turned out to be negative. So because we had abnormalities in the CBC and the peripheral blood film, that's the only clue we got We had to perform a bone marrow biopsy in this patient to see what was the actual reason for the B12 and folic acid deficiency and to confirm that this was vitamin B12 and folic acid deficiency anemia. On the bone marrow biopsy, we got hypercellular smear in which erythropoiesis was frankly megaloblastic, and this erythropoiesis was seen with maturation arrest. And there was no other evidence of granuloma or extramedullary deposits seen. This confirmed that the patient had megaloblastic anemia, which was due to vitamin B12 deficiency. Now, vitamin B12 deficiency, as we discussed in the beginning, can be one of the causes of elevated levels of homocysteine in the blood, which can lead the body into a hypercoagulable state. So we did the vitamin serum, we checked the vitamin B12 levels in the blood, and we also checked for the folic acid and homocysteine levels in the blood. Homocysteine levels were found to be elevated and were most likely the cause of this patient's ischemic stroke. The high elevated levels of homocysteine in the blood led his body into the hypercoagulable state and the formation of thrombus, which increased the risk of this patient of ischemic stroke and also predisposed this patient to cardiovascular risks like heart attack, MI. So in this case, upon presentation, it appeared to be a case of ischemic stroke, but it is very unusual for an age group of an adult who is 18 years old. As we know that ischemic stroke is extremely uncommon in this age group, this patient upon presentation appeared to be a case of ischemic stroke, and we needed to figure out what was the cause. The most common causes in young age group leading to ischemic stroke could be vasculitis, protein C and S deficiency, antithrombin 3 deficiency, or any other underlying autoimmune diseases. However, this patient tested negative for all of these, and the only clue that came to us was from the CBC, which showed to us megaloblastic anemia, which was due to vitamin B12 and folic acid deficiency. The patient's home tests were also negative, making the autoimmune disease unlikely. So the only thing we had left was to check the levels of B12 in the serum and levels of folic acid, and as well as homocysteine. Now, for all patients which present with stroke, after the initial workup has been done, which includes an ECG, an echocardiogram, a carotid Doppler, and a lipid profile. If all of these turn out to be normal, the patient is young, and there are no other comorbidities like hypertension or diabetes mellitus or any other dyslipidemia. The patient should be further investigated, and if the CBC is also indicative of B12 deficiency, the homocysteine levels should be checked for sure. Now we need to discuss about the causes of hyperhomocystinemia and vitamin B12 deficiency. Vitamin B12 can be deficient due to insufficient dietary intake. It can also be deficient in people who suffer from IBD as well as pernicious anemia, or if the patient is taking metformin for a long time, is also a reason for decreased levels of B12 in the body. Now, the symptoms that could start appearing in such patients are symptoms of anemia, which include pallor, shortness of breath, fatigue, but specifically in B12 deficiency anemia, the patient will experience memory problems, poor muscle function. There may also be glossitis, and there may be glove and stocking paresthesia. That means paresthesia in your hands and in your feet. So the awareness about B12 deficiency anemia should be spread among people to avoid any further complications. The diagnosis is very simple through a CBC and peripheral blood film. It's all that's required to exclude and rule out B12 deficiency anemia. Now, the treatment is basically just diet modification. We can add the vitamin B12 and folic acid supplements in the diet of the patient to improve the levels. We can offer the patient oral supplements as well as intramuscular injectables to replenish the vitamin B12 that's being lost. Now, the conclusion for this case discussion is that the majority of the hyperhomocystinemia is caused by folic acid and vitamin B12 deficiency, which can be due to dietary insufficient intake, malabsorption, and autoimmune disorders. And correcting the nutritional adequacy of vitamin B12 and folic acid will lower the homocysteine levels in the blood, which will prevent the body from which will which will prevent the hypercoagulable state in the body, thereby reducing the risk of cardiovascular and cerebrovascular complications. This patient was treated with oral and as well as injectable vitamin B12 and vitamin B12 supplements. After supplementation of vitamin B12 and folic acid to this patient for 2 weeks, the patient's power had improved to 5 by 5 in the right lower limb and improved to 4 by 5 in the upper limb, and the patient's CBC also came back normal after 2 weeks of supplementation. The peripheral blood film showed normochromic and normocytic RBCs, and platelets also came to be normal. The the emphasis is on the importance of vitamin B12 and folic acid intake in our bodies. How important it is to take these vitamins to to prevent any complications in the body. I would once again like to thank California Institute of Research and Technology for giving me this opportunity to present at this symposium, as well as I'm extremely grateful to Dr. Barney, who has been my mentor throughout this journey and helped me a lot figure out this presentation. Thank you so much.